Good morning, everyone. I'm Dr. SRUTHY Sundar, currently working as a senior lecturer at Malabar Dental College and Research Center, Edapal. I completed my post-graduation in periodontology from Royal Dental College, Palakkad. Today, as part of the reading club conducted by GCOA International Implant Summit 2026, we will be discussing Section 5 of Misch Contemporary Implant Dentistry. Let's begin with Chapter 20, Treatment Plans for Partially and Completely Edentulous Arches in Implant Dentistry. The Kennedy classification divides partially edentulous arches into 4 classes. Class 1 has bilateral posterior edentulous spaces. Class 2 has a unilateral posterior edentulous space. Class 3 has an intradental edentulous area. And Class 4 has an anterior edentulous area that crosses the midline. The Kennedy classification is difficult to use in many situations without certain qualifying rules. The 8 applicate rules are used to help clarify the system. They may be summarized in the 3 general principles. The first principle is that the classification should include only natural teeth involved in the final processes and follow rather than precede any extractions of teeth that might alter the original classification. This concept, for example, considers whether second or third molars are to be replaced in the final restoration. The second principle is that the most posterior edentulous area always determines the classification. The third principle is that edentulous areas other than those determining the classification are referred to as modifications and are designated only by their number. The classification of partially edentulous arches, we will discuss it with the figures. Class 1 Division A, where dental arch has bilateral posterior missing teeth and abundant bone volume in the edentulous site. Class 1 Division B, dental arch has adequate height of bone but is barely sufficient in width. Class 1 Division D, patient is usually seen in the maxilla when the maxillary sinus has expanded and less than 5 mm of bone is present in height under sinus. If in case a patient is having Class 2, has posterior missing teeth in one quadrant, when the available bone is abundant, it is Division A. A Class 1 Division C H arch has 7 to 9 mm of bone in height in the edentulous site. A Class 3 patient which has an intra-tooth edentulous space, when it is adequate in height but barely sufficient in width, it is Division B bone. A Class 3 Division D patient is more often observed in the maxillary arch. A Class 4 Division C H dental arch has compromised bone in height. If the bone is compromised in width, it is CW. A Type 2 Division A-B arch has an anterior section classified as Division A and posterior sections classified as Division B. The anterior region dominates the overall treatment plan in all edentulous arches and usually has a greater volume of bone than the posterior. Type 3 Division A-B-D arch has abundant anterior bone, moderate atrophy of bone in the posterior right, and severe atrophy in the left posterior segment. Sinus grafting is a common treatment if posterior implants are required in the maxilla. However, bone augmentation in the posterior mandible for Division D is more unusual and additional anterior implants in the Division A with a cantilever are more typical. Another option is to use narrower implants in the right posterior, splintered to the anterior implants. Moving on to next chapter, Chapter 21, Pre-implant Prosthodontic Factors Related to Surgical Treatment Planning. There are 5 initial elements that should be assessed in sequence and treated when indicated. These elements include maxillary anterior tooth position, the existing occlusal vertical dimension or OVD, the mandibular incisal edge position, the maxillary occlusal plane, and the mandibular occlusal plane. These elements are evaluated in a partially edentulous patient during the initial clinical examination and on mounted diagnostic cards, which may also serve as diagnostic wax-up procedures. The sequence of treatment include first one overall evaluation, maxillary anterior tooth position, occlusal vertical dimension, mandibular incisal edge, maxillary posterior plane, mandibular posterior plane. The specific criteria include high and low lip line of maxillary and mandible, maxillomandibular arch relationship, existing occlusion, crown height space, temporomandibular joint status, extraction of hopeless or guarded prognosis existing teeth, existing processes, arch form, whether it is ovoid, tapering and square, natural tooth adjacent to implant site, soft tissue evaluation of edentulous site. Moving on to the crown height space. The inter-arch distance is defined as the vertical distance between the maxillary and mandibular dentate or edentate arches under specific conditions. Example, the mandible is at rest or in occlusion. A dimension of only one arch does not have a defined term in prosthetics. Therefore, Misch proposed the term crown height space. Crown height space or CHS for implant dentistry is measured from the crest of the bone to the plane of occlusion in the posterior region and the incisal edge of the arch in question in the anterior region. The ideal CHS for an FP1 fixed implant prosthesis should range between 8 and 12 mm. This space accounts for the biologic width, abutment height for cement retention or prosthesis screw fixation, occlusal material strength, aesthetics, and hygiene considerations around the abutment crowns. Excessive crown height space. The biomechanics of CHS are related to lever mechanics. The issues of cantilevers and implants were demonstrated in the edentulous mandible, in which the length of the posterior cantilever directly related to complications or failures of the prosthesis. Rather than being a posterior cantilever, the CHS is a vertical cantilever and therefore is also a force magnifier. When the direction of a force is in the long axis of the implant, the stresses of the bone are not magnified in relation to the CHS. However, when the forces to the implant are on a cantilever or a lateral force is applied to the crown, the forces are magnified in direct relationship to the crown height. Bides and Misch have evaluated the effect of a cantilever on an implant and its relation to crown height. When the crown height is increased from 10 to 20 mm, 2 of 6 of these moments are increased 200%. When the available bone height is decreased, the CHS is increased. An angled load to a crown also magnifies the force to the implant. The greater the crown height space or CHS, the more implants are required to restore the patient. The less the CHS, fewer implants are required to restore the patient. Excessive crown height space treatment planning options to decrease the stresses are: shorten the cantilever length, minimize buccal and lingual offset loads, narrow the occlusal table, increase the number of implants, increase the diameter of implants, design implants to maximize the surface area, fabricate removable restorations, less retentive, and incorporate soft tissue support, remove the removable restoration during sleeping hours to reduce the noxious effects of nocturnal parafunction, splint implants together regardless of whether they support a fixed or removable processes, and maintains vertical dimensions and prevents soft tissue collapse. Attaching implants to teeth. Before 1988, many practitioners connected an implant to one or two natural teeth. These implants were designed to have either a fibrous tissue or a direct bone interface. When the root form osseointegration concept of Brennemark for full arch edentulous fixed processes became more dominant in the mid-1980s, these implants came to be used in partially edentulous arches. It was hypothesized at the time that joining a rigid implant to a natural tooth would cause biomechanical complications on the implant. Splinting a rigid implant to a natural tooth has caused concerns relative to the biomechanical differential in movement between the implant and tooth. Because the tooth moves more than the implant may receive a moment force created by the cantilever of the processes. 3 or 4 unit precious metal processes with an implant and a posterior tooth rigidly splinted has some inherent movement. The implant moves apically 0 to 5 mm and the tooth moves apically 8 to 28 mm but can rotate up to 75 mm towards the implant because of a moment force. The metal in the processes can flex from 12 to 97 mm depending on the length of the span and the width of the connecting joints. The abutment to implant component movement may be up to 60 mm because of abutment prosthetic screw flexure. As a result, a vertical load on the processes creates little biomechanical risk when joined to a non-mobile tooth because of the design. Moving on to the tooth and implant movement. Under normal conditions, the same force applied to a tooth and an implant results in the tooth moving significantly more 28 micrometer compared with an implant which is 5 micrometer. Non-rigid connectors are contraindicated. A mobile attachment between the implant and natural tooth is usually not a benefit. A mobile attachment moves more than an implant or a tooth. Therefore, it is not an attachment. The ponding is cantilevered from the implant with little or no support from the tooth. It is usually better to have a rigid connector between implants and teeth than a mobile attachment. Moving on to Chapter 22, Single and Multiple Tooth Replacement Treatment Options. Take a look at the advantages and disadvantages of fixed partial denture. Advantages include fast treatment, restores function, aesthetics and intra-arch health, proven long-term survival, reduced cost, requires minimal crown height space for retention. The disadvantages are increased rate of caries and endodontic failure of abutment teeth, increased plaque, irreversible preparation of abutment teeth, fracture complications like porcelain tooth, aesthetics complications like crowns like aesthetic than natural teeth. Whereas the advantages and disadvantages of implants are, in implant, the advantages include less risk for caries, endodontics, restoration and tooth fracture, unretained processes, no preparation of adjacent teeth, improved hygiene conditions, improved aesthetics in most cases, maintains hard and soft tissue bond at site, decreases adjacent tooth loss. Disadvantages include increased treatment time, possible hard and soft tissue grafting. Next, single tooth implant size specifics. When evaluating the size of the dental implant, specific guideline measurements should be adhered to. 1.5 to 2 mm from an adjacent tooth, 3 mm between implants, 2 mm from a whiter structure, 1.5 to 2 mm of buccal bone after the implant placement, 1 mm of lingual bone after implant placement. Now let's discuss about the disadvantages of replacing second molars. Not in aesthetic zone, extruded maxillary second molar not aesthetic or occlusal consequence, less than 5% of total chewing efficiency in this region, a 10% higher bite force which increase the bone loss risk, porcelain or zirconia fracture risk, and abutment screw loosening risk. More often exhibits occlusal interferences during excursions, higher and less predictable location of mandibular canal in that site, less dense bone, submandibular fossa depth greater, angulation of bone to occlusal plane is greater, limited to unfavorable crown height space for cement retention, which increase risk for uncementation, limited access for occlusal screws placement, limited access for correct implant body placement, crossbite position, implant placed more buccal than maxillary tooth, hygiene access more difficult, cheek biting more common, more incision line opening after surgery, greater mandibular flexure during parafunction, and greater cost to patient. Now let's discuss about the advantages and disadvantages of screw retained crowns. Advantages include retrievable, non-retention, no risk for leaving residual cement, limited interocclusal space. The disadvantages include highly dependent on implant position, which is unaesthetic, access hole, more expensive, occlusion where access hole wearing, multiple splintered units passivity, porcelain fracture where unsupported porcelain. Whereas the advantage and disadvantage of cement retained crowns are, advantages include more passive, less expensive, enhanced aesthetics, traditional prosthetics, which is conventional laboratory techniques, more freedom of implant position. Disadvantages include use of cement, unknown retention can be difficult to remove.
Thank you everyone.